Good day, everyone. Welcome to today's AFOMP webinar on advances in application and research of spatially fractionated radiation therapy. We are privileged to have Dr. Xiangliang Wang as our speaker today and Dr. Jiayun Chen as our moderator. So I would like to welcome both of you for today's webinar along with all the participants who are logged on. And to introduce our moderator, Dr. Jiayun Chen. She is an active member of the Asia-Oceania Federation of Medical Physics from the Chinese Medical Physics Society. And she is a member of the ETC, Education and Training Committee of AFOMP. And she works as a medical physicist and associate professor at the Department of Radiation Oncology, Cancer Hospital, Chinese Academy of Medical Sciences. And she has a lot of awards, publications, patents, and even organizational milestones to her credit. Without going into the details of that, I thank and welcome Dr. Jiayun Chen for agreeing to moderate today's session. And over to you, Dr. Chen, to carry forward with today's webinar.
Okay, thanks for your introduction, Mary. And it's my honor here to be welcome our Professor Xiangliang Wang from China. Today, his topic is about advancing application and research of spatially fractionated radiotherapy. As we all know that SFRT right now currently is a great hot topic, and Professor Xiangliang Wang did a lot of contribution about this work. Let me take a few minutes. Allow me introduce our speaker, Professor Xiangliang Wang. Professor Xiangliang Wang is a medical physicist at Sichuan Cancer Hospital and Institute. He holds a PhD in nuclear technique and application from Sichuan University. He is currently the duplicated director of radiotherapy department of Sichuan Cancer Hospital and Institute. He is also a member of the Quality Control Expert Committee of Tumor Therapy of National Cancer Center and a member of the Physics Group of Radiation Oncology branch of the Chinese Medical Association. His research is focused on precision and automatic radiotherapy for cancer patients. And he also has lead over 10 research projects and published a lot of good excellent paper. And let us welcome our speaker, Professor Xiangliang Wang.
Thank you. Okay, now first I should share my screen. Oh, yes. Hello, everyone. It's a great honor to be here to give a talk about advancements and application for SFRT. I'm a medical physicist, so today I will focus on physics aspects of SFRT. The contents has three parts. One is the overview of SFRT. The second is clinical applications. Third one is research, mostly about the experience from our hospital. This first one is overview of SFRT. Here is a new concept. It's called spatial temporal radiotherapy. We all know the temporally fractionated radiotherapy. We used it for example, hypofractionation or hypofractionation. This is we use different biological basis of this is 4 principles of the biological basis of fractionation radiotherapy. We use different time. Then here is a technique about how we divided the dose into we call it inhomogeneous dose. This is SFRT. The different dose distribution compared with conventional radiotherapy, it will cause unique biological effects. Up to now, we still don't know exactly what happened about SFRT. There's many radiobiological aspects influence the clinical outcomes. For example, bystander effects, vascular effects, or immune effects. We still don't know. It's still under research. But the clinical outcome we have observed, then I will show you some pictures about the treatment of patients. This is a radiobiologic study carried out at our center. We use micro beam radiotherapy. I don't want to go too in detail, but we can see from the picture C, the maximum dose we can add it to 150 gray. So the side effects still under control. So if we use conventional radiotherapy, so high dose, we can imagine the side effects. But if we use microbeam or SFRT, the side effects is under control. Also, today there's some research they want to combine SFRT and flash together. We call it spatial temporal radiotherapy. The reason is both SFRT and flash, they can improve the anti-tumor immunity, also reduce the normal vascular toxicity. They both can have the same function. Also, they even they have different mechanisms. This is a picture about SFRT. SFRT is deliver intentionally heterogeneous radiation dose to the target volume. It's quite different from what we have learned from conventional radiotherapy. In conventional radiotherapy, we want to keep the dose of the target volume more homogeneous. But here, SFRT, we intentionally deliver a heterogeneous radiation dose. The technique was developed from almost 100 years ago. From the very beginning, we used grid radiotherapy. The grid radiotherapy is like we use blocks. Then there are some holes at the block, so we can get an inhomogeneity dose. But now, clinically, we commonly use the lattice. Means we have many vortex or high dose readings in the target volume. This is what we have used clinically. Also, today there are many papers published. The SFRT clinically used is lattice radiotherapy. This is a comparison of different SFRT techniques. The first one is grid. We use some block to generate a homogeneous dose. The second one is lattice radiotherapy. In the target volume, we have sub target volumes. We call it boost target volumes. Different volumes. The diameter of the boost target volume is about 1 centimeter or less than 1 centimeter, but it has many small boost target volumes. The number depending on the target volume and the organs at risk. Then we use the different. We use many beams to generate to get a dose distribution we want. At the bottom, the first one is we call it macro beam radiotherapy. It uses beams very narrow, less than millimeter. Now clinically the clinical publication is not too many publications about the clinical outcome, but many research on animals, especially on rats. This one is, we call it a mini beam radiotherapy. The width of the beam is about millimeter. So we can use some block to generate this. And this is for the 4 techniques used to generate SFRT. Also in our center, we have proton therapy. So we have collected many papers we want to know whether a proton mini beam radiotherapy has advantage. So we have a review paper published last year in Frontiers in Oncology. If you have interest, you can read this. This is a photo about SFRT research. I used radiotherapy and the SFRT as keywords. There are search. We can see from here, there are many publications recent years, especially we can see from here, 2025, the publications for 2025 is larger than 2024. Also, we are glad to see that the third paper, the third one is the research we have done. We have published in CTRO. The first one is the background about SFRT. Then the second part is about clinical applications. In our center, we have a large number of patients. At the beginning of last year, we have treated more than about 300 patients with lattice technique. This is the basic patient data. So I want to this page is in Chinese. I just want to mention that when we studied SFRT technique, we have no clinical experience. We have a lot of discussion with centers from other hospital. Also last year we have some clinical experience, so we have a training course last year held in our hospital. There are more than 400. We call it 403 physicists or physicians from different provinces in China. They joined this meeting. Also, from this meeting, we learned a lot. This is a patient data. Before SFRT, we can see from here. Before SFRT, there's a big target volume here. After the treatment of SFRT, the outcome of the patient is like this. The left is the acidosis distributions. We can see from this picture that if the patient was treated with conventional uniform dose radiotherapy, we can control the target. We can control the tumor growth, but we also can imagine the side effects of the skin. So we chose the SFRT technique to treat these patients. This is paper we have published in CTRO. This is it collected 19 head and neck cancer patients. 13 of them failed one-line therapy, and the treatment outcome is no grade 3 toxicity. Among them, 19 patients, 16 patients have a tumor regression. Also, 10 patients had a PR. The outcome is, we can see the patient data shows the clinical outcome. This is a case report. This patient has is metastatic colon cancer, but the tumor volume grows fastly. We can't treat it with conventional methods, so we chose SFRT. The patient died about half a year after the treatment, but here I want to say it died because of the tumor was metastatic. From the picture we see that the site we treated, the side effects is controlled. The tumor shrinked a lot. And the third part is about research. The first one is when we do lattice radiotherapy, the first question is where should we place the lattice? Or where should we place the vortex, the high dose region? This is the first question. When we use lattice technique, we read papers about how to generate lattice volume, use algorithm. It's like this. From the concepts, we developed the software to generate the lattice. This is a software, in-house software. From this software, we can see at the very beginning, we don't know the parameter of the lattice. For example, what should be the radius of the lattice? Also, the center to distance from this lattice to another one. What's the distance between them? Also, the lattice is the highest dose. We should avoid it from the edge of the target. We should place the high dose in the target volume, not at the edge of the target volume. Here we shrink the target 1 centimeter. So at the first beginning, we don't know the best parameter. We generate a set, different sets of combinations. We use different combinations. For example, the vortex radius is from 2 millimeter to 4 millimeter. The center distance from 2 millimeter almost to from 20 millimeter to about 40 millimeter. That's what we want to try. Which one is the best? So how to evaluate? When we want to get the best one, we must know how to evaluate. There are 2 parameters very important here. The one is PVDR, means peak to valley dose ratio. Peak to valley means this is peak dose. This is at the middle of the peak dose. That's valley dose. This is we want to get a higher PVDR, a peak to valley dose ratio. Another parameter is ablative dose ratio. We call it ADR. ADR means the high dose, the high dose volume divided by the target volume. Means the larger the better. But they are sometimes they are. We must find a balance between PVDR and ADR. Since if we want to have a higher ADR, we must add many lattice into the target volume. But it's difficult for us to get a higher PVDR. In the other words, if we want to have a higher PVDR, we'd better have a large distance from large center to center distance of the lattice. So it's in our opinion, we all think this is optical. This is a question we can use optimization algorithms to optimize it. So the second is how to optimize lattice position. And you can see this study is has published at 2024. It uses the methods we have mentioned. It first generates a set of lattice, then at the target volume it routed, but the combination was not changed. Then they find the best like we have evaluated clinically the best dosimetric parameters, the best target coverage, and the best protection of OARs. This is what they have done. Another study used different methods. It generates different sets of lattice. For example, the lattice radius from 2 millimeter to almost 10 millimeter. The center to center distance from 10 to 30. It generates different sets, then calculates for each one. Then they combine. Then we calculate the objective value. The lowest one, then maybe they think is the best one. In our center at the first, the clinically commercially treatment planning system didn't support the optimization, since we can't use commercial TPS to generate what we want. So we did assumption that the peak dose, the lattice dose, like the acid dose line, is like a Gaussian function. We use Gaussian function to fit the dose distribution. We want to use these methods to get the best dose distribution. Also, we program. We have a small program to do this. After the program, this program actually we never clinically use, since there are many factors influence the Gaussian function. For example, the MLC, the thickness of MLC, also the target volume. The larger target volume, the bigger parameter of the Gaussian function. Also, the OER, the distance of OER between OER and the targets. These factors all influence the Gaussian function. So different. If we test on one patient at one linac, it can't be used at another linac, since we have to modify the Gaussian function, the parameter of Gaussian function. So we don't use it clinically, but we applied patterns. Now we know that some research groups at America, they use these methods. They get an ideal dose distribution. Also, we have applied many grants from our country. When the first method didn't work, we tried another method. We want to use biology guided radiotherapy. Since we don't know how to optimize the lattice position, now we want to use a biological signal to get the lattice position. Here we have published a paper about we use the MRI image, the ADC value of the MRI. We use the ADC values to generate the lattice volume. Then we compare the distribution and the parameters. For example, PVDR and ADR. We use these parameters to get a dosimetric comparison between biological guided SFRT and the conventional lattice radiotherapy. This is a paper we have published in the Red Journal. If you have interest, you can download and read. The next is actually in our hospital we have different simulation equipment and radiotherapy equipment. So we have Electa, Varian, also Tomo, Subknife, also proton therapy. We have different treatment equipment. So we want to know which one is more suitable to do SFRT. So we did a lot of dosimetric comparison between different methods. The first one is we use VMAT and Tomo. We compared VMAT and Tomo methods. Frankly speaking, in our center we get almost the same data. We don't think Tomo has many dosimetric advantage over VMAT. But recently, some people they have published that Tomo has dosimetric advantage. That's why that might be influenced by the clinical experience of physicists who do this research. The second one we did, we have Subknife. The Subknife has lower penumbra, so ideally it has it can get a higher PVDR. This has an advantage. So we want to use Subknife to design a treatment plan. Yes, from Subknife, if we use Subknife, we only use Subknife, we can get a higher PVDR, but the treatment time is very long since Subknife commonly used for small target volume treatments, but for SFRT, they commonly used for large target volumes. Maybe a patient need one. We can design a treatment plan, but the beam delivery time maybe over one hour. It can we can't accept it clinically, and that means we can't clinically use the treatment plan that treat the patients over one hour. So we want to combine whether we try whether there's a feasibility we combine Subknife and VMAT together. We get ideal dose distribution. Also, the treatment time can be reduced. Yes, we have published this paper. If you have interest, we also published. We get ideal dose. But frankly speaking, the PVDR was better than VMAT, but lower than Subknife. So, but the treatment time is acceptable. Then also in our center we have MR-Linac. You see, for SFRT, we design a treatment plan on an image, but the image was don't have movements. But the real patients, when we treat the patients, the target volume was moved. When the target volume has movements, the beam delivery is not precisely at the location we have planned. So maybe the high dose and the low dose was blurred. The blurred dose, that's the reason I think some physicians from our they have learned SFRT from our hospital. When they did the patients at their center, they sometimes they will say, well, in our center we have tried SFRT, but the clinical outcome was not so good. I think there may be some many aspects influence this, but the target movements I think is the most important one. If we don't have a good movements control, we can't get ideal clinical outcome. Also, we have published the methods we have done. We have used when we use MR-Linac. There's a new technology about SFRT. It's called PASI. means partial tumor radiation. From this figure, we can see that the left one maybe is the lattice. We have many lattice volumes. It's not easy for us to generate lattice. Also, it's not easy for us to generate a plan if we want to get a higher PVDR. But for PASI, it's more easier. It only have one boost volumes at the almost the center of GTV. So we want to compare the dosimetric, whether it has dosimetric advantage over conventionally used SFRT. We have for the same patient we designed a treatment plan. Yes,